Good day. Today we're going to continue our look at the reproductive system by examining the anatomy and the physiology of the female reproductive system. And we'll take a look at both the physiology of menstruation as well as the physiology of reproduction. Let's look at the external genitalia first. We begin here with this external artist view and pretty much see exactly what we saw in the last lecture. The external genitalia, the labia on both sides, is called the vulva. It comes from the word vulvare, which means to wrap around. It's also known as the pudendum. Now, there is a small prepuce that covers the clitoris, which is the analog of the foreskin. Clitoris is sensitive to stimulation, as is the glans, penis in the male, and it's the analog to the glands. It has served no other purpose other than sexual stimulation. The analog to the male scrotal skin and hair is the labia majora on both sides here, and then the labia minora secretes the oils of lubrication for sexual intercourse. Now, there is something called a vestibule, which is located between the labia minora, and then we enter the area of the vagina. Now, there's a membrane called the hymen, which is a very thin mucosa-covered membrane that usually has small perforations in it. It covers the vaginal orifice. It's easily disrupted by the time most women reach puberty, either from athletics or other minor traumas. The hymen has been destroyed. On occasion, there are hymens that don't have any perforations. It's called an imperforate hymen, and that leads to the problem that once the child starts menstruation, blood can't escape, and that has to be surgically opened to allow blood to escape through the vagina. There are glands, just as in the male side of the anatomy. There are something called Skene's glands or paraurethral glands. They come on either side of the opening, and they are the analog to the male prostate. They secrete mucus. And then there are Bartholin's glands, which are called the greater vestibular glands, and they secrete mucus as well during intercourse. Their analog in the male is the Cowper's glands. And finally, right in front of the pubic bone is usually an extensive deposition of fat called the mons pubis, also called the mons venaris, the mount of Venus. And this is to protect the pubic bone against trauma and pain during intercourse, something that evolution would favor. This is the sagittal section we're looking at now. And you can see very slight differences. Here's the clitoris pushing its way out under the labia. Here's the opening to the vagina, and here is the external opening of the urethra coming from the bladder and between the clitoris and the vaginal opening. If you'll notice, there's the perineal body and then the anus close behind. Tucked and wrapped anteriorly is the urinary bladder with its opening and its muscles. It's a wholly extraperitoneal organ. Again, look where the peritoneum comes down and then covers the bladder and dips into this pouch here, which is called the vesico-uterine pouch, the bladder uterine pouch, and comes back up again on the uterus as visceral peritoneum. And the fallopian tubes are also covered in visceral peritoneum. So all the female reproductive organs, unlike the male, are actually intraperitoneal organs. And then the peritoneum reflects back again, covering the rectum, which we remember was an extraperitoneal organ. It's also important to look at the proximity of things. Here we have the cervix, where it is protruding into the vagina at the top. Now, you can see, therefore, that the cervix is extraperitoneal. And here we have the vagina, which is really a potential space. In normal situations, it is collapsed. It is heavily rugated. It has these folds which provide friction for sexual stimulation of the male during intercourse, and it protrudes down here at the very top end of the vagina. It is easy access for instrumentation, so we can look up in here and we can get access to the inside of the uterus if necessary. We could also, as is done frequently, remove the uterus without ever going into the abdominal cavity. There are abdominal hysterectomies, but there's also vaginal hysterectomy, where we can cut the membrane all around on the peritoneal side of the cervix. The uterus can then be pulled down into the vagina, separated from the fallopian tubes, or the fallopian tubes taken, and you can do this complete operation through the vagina without an abdominal incision. It can also be done by coming above the pubic bone and back here behind the bladder and taken out that way. That's much more surgery. Also have something else in close proximity. Here's the rectum lying a very short distance away from the vagina. We can actually go through the rectum and palpate different organs, feel for tumors. We can do biopsies through the rectum the way they can be done in the male, getting to the prostate. So we have lots of access here because of the way the anatomy is laid out. If we look at a different view, here's a patient who's had a horizontal section taken through the body. We are looking down into the pelvis. This is the view that a surgeon would have if the abdomen were completely opened. Here's the abdominal wall, the rectus muscles, and right around both sides is the pelvis. So now we're looking down into the pelvis. This is the patient's right. This is the patient's left. Here's the back. So we have the cecum and ascending colon on this side, and then ending over on this side, descending sigmoid colon and down into the rectum. We have the rectum separated from the bladder, which is different in the male, where it's right against the bladder. Here we have the uterus in the middle, and this one is kind of flopped forward the way it was in the other picture. Look what we have here. We have something called the round ligament. It's coming up and out and then ducts behind the peritoneum to exit just the way the male spermatic cord did, only the male stayed extraperitoneal the whole time. This is a vestigial structure. It supports the uterus, but it's the analog to the male spermatic cord. Here we have the top or the dome of the uterus, and then the fallopian tube curling up and back to rest on top of the ovary on either side. Anatomically, very important. We have a pouch down here called the pouch of Douglas. Infections might find their way down here, abscesses. If there's a problem with the rectum or the sigmoid, for example, perforation from diverticulitis, it could actually penetrate low down into the vagina, and you have a recto-vaginal fistula, where feces might leak into the vagina because of this inflammatory process or a surgical injury. We have the uterus up here. Again, we can have fistulas between the urinary bladder and the vagina, or injuries that affect both these organs. Look also down here, vermiform appendix. Remember the appendix from our lectures on the digestive tract? The appendix sits almost right on top of that ovary. There are diseases such as something called pelvic inflammatory disease or tubo-ovarian abscess, where we can get gonorrhea or other bacterial infections up through this tube, out onto the ovary, and we can get a great deal of confusion as to whether this is appendicitis or whether it is tubo-ovarian abscess, known as TOA or PID, pelvic inflammatory disease. History should tell you that. Remember, appendicitis starts around the belly button, works its way down to the right lower quadrant. This patient might tell us about vaginal disorder, discharge because of her infections, with no umbilical pain at all. This one would be much more chronic over a longer period of time. So history is very important. The vagina is the conduit that carries the sperm to the cervix, And there's often a mucus plug in the cervix, which is not there during the time of ovulation. So this allows the sperm to get up to where they should be. The uterus itself is cut on section here. It's a very muscular organ. Obviously, this can stretch out and become enormous during pregnancy. The fallopian tubes stick out on either side and, of course, are in continuity with the interior of the uterus. Now, if we look at the next slide, this is a rather artificial cutaway. It's the artist's imagination to show us the most of this entire reproductive system. Here's the vagina showing the rugae. And here the artist has cut away a quarter of the uterus. So we show the canal. There's an external os or opening, and then there's a narrowing and an internal os or opening leading to the main uterine cavity. The cervix sticks down into the vagina. Cervix is the same word for the one in the neck. This is the uterine cervix because it's the neck of the uterus. And there's the body and the fundus. It is lined with something called endometrium, or the lining over the muscle of the uterus. Then there's the myometrium, the muscle layer, and here's the visceral peritoneum. Finally, the tubes come off a narrowed opening here. This is called the isthmus, the pathway, the ampulla, which is a wider opening, and finally the infundibulum of the uterine or fallopian tube. These little fingers can swirl. They're called the fimbria of the fallopian tubes. And they can create a little bit of suction so that when the ova or the egg bursts off the surface of the ovary, and I'm going to show you that in just a moment, it'll be sucked up into the tube where it'll make its passage through muscular contractions back down into here where implantation can take place if fertilization has occurred. The uterus has a couple of problems associated with it. There are cancers of the endometrium called uterine cancer. These are very readily cured these days with early diagnosis and surgery or radiation. We also can get benign tumors of the wall of the uterus called fibromas or leiomyomas. They're sometimes smooth muscle tumors. And these tumors are generally benign, but they cause problems by their size. They can be very big. The uterus can try, because it has smooth muscle, to get rid of it. It tries to pass it out. It can't do that because the tumor is part of the wall of the uterus, but the uterus contracts and causes cramps for the patient who has this. The uterus can also prolapse. We can lose pelvic support, especially with aging and after childbirth. So if you look here, what can happen is this uterus can start sinking down into the pelvis, where it becomes a problem, because in serious prolapse, this uterus can make its way all the way down through the lax pelvic wall, be sticking into the opening of the vagina, or actually right out of the vagina. And these have traditionally been treated by something called a pessary, a steel or plastic ring put in here to hold them up in place and prevent prolapse, or by mechanical repair, suturing the ligaments, or finally, out of desperation, just hysterectomy, removal of the uterus. And all these things can be done for these patients. Finally, one of the most common cancers in the world is cervical cancer, which is a sexually transmitted disease. I'm going to talk more about this in the last lecture. Basically, this cancer is caused by a virus that is passed through sexual partners called human papillomavirus. It causes benign warts, venereal warts, but also cervical cancer. Very common cancer, very easy to diagnose because we have easy access to this. A gentleman named George Papanicolaou was a pathologist at Cornell just before I was there. And Dr. Papanicolaou found that by scraping the surface of the cervix with a wooden spatula and smearing the cells onto a slide, spraying it with formaldehyde and staining it, he could look at the uterine cervical cells and see whether they were atypical or frankly cancerous. He could make a very early diagnosis of cancer before the cancer had invaded or became apparent. This is called the Pap smear. And we now use Pap smears for the diagnosis of cervical cancer, as well as cancers elsewhere where we have access to the surfaces of the body. We can actually go inside the lung, inside the stomach with a fine wire brush, get some cells back, smear them on a slide. It's very minimally invasive, very inexpensive, and quite accurate. It has caused the mortality for uterine and cervical cancers to just plummet because of early diagnosis and nothing else. Worldwide in use, and really one of the great contributions to medical science in the treatment of this terrible disease. Also in the uterus, we have some other problems. In the fallopian tubes, you will see as we move along here that fertilization usually takes place somewhere up in here. The egg starts its way down and will meet the sperm all the way up here, and then takes several days to make its way down into the uterus where it implants. Occasionally, the sperm may get trapped up in here for one of several reasons. If a patient has had, for example, repeated gonorrhea, pelvic inflammatory disease, that patient may have partial scarring in the tube from old disease. The sperm might be able to get past that because they're very small, make the fertilization occur high, and then not be able to get back. We then have implantation here in the tube. This will grow to a certain point because the tube has a good blood supply, and then it will rupture through the wall of the tube. This is called an ectopic pregnancy, and a ruptured tubal pregnancy becomes a surgical emergency because most of these patients now have established a very rich blood supply, and they hemorrhage dramatically. This can be a life-threatening condition, usually treated with surgery and removal of the tube rather than repair. Now, because we also have another tube on the other side, it does not mean that that patient will necessarily be infertile. They may be if that tube is also scarred. If the scarring is particularly severe, then nothing can get up. Sperm cannot get up the tube, eggs can't get down the tube, and the patient is infertile. There are some operations to correct this, but not highly successful. The fertilized ovum spends about a week in the tube in transit, and so a lot of development occurs during that first stage. Now the ovaries, which we'll look at next, are on either side of the uterus. And this shows the ovaries as we see it cut again on sagittal section. The male makes sperm all throughout his life, usually into late old age. The female is born with all the eggs that she's going to have, usually about 400,000. She's not going to have 400,000 periods, so there's great excess here, great redundancy. Since the female will menstruate usually once a month, release an egg once a month from the time of 12 or 13 to sometime in the 40s and 50s, you can see we're going to have a huge backup of extra eggs that are not necessarily going to be used. I want to go through how the eggs mature and what they do on the way down the process of the normal cycle for a single egg. Let's look at this picture. Here's the egg with its blood supply coming in from the hilus of the mesentery that holds the egg. And this is going to show the progression as if it happened moving around the surface. It doesn't. It all happens in one place. This is purely for artistic benefit to be able to show you each stage. We have something called a primordial follicle. This is the same stage we saw with the stem cells of the sperm. These cells mature slowly, becoming bigger and bigger. This is a primary follicle. A follicle is a small hole. These enlarge slowly during the menstrual cycle until we get a follicle that starts to begin to be filled with fluid. This labeled the germinal epithelium is where these eggs come off. They don't come from deep down in here. They come off the edge of the surface. When we get to a certain size, the follicle is filled with fluid, and this is called a mature Graafian follicle. And here's the egg material at its side. Finally, at about mid-cycle, the Graafian follicle ruptures, expelling the egg into the peritoneal cavity. And at that point, the egg will make its way by being sucked up in the fimbriated edges of the fallopian tube. Now, the Graafian follicle continues to function. After it discharges the egg, it continues to mature. We sometimes see this structure with a blood clot in it. That's just after the follicle ruptures. There's a very rich blood supply, and occasionally a few drops of blood will spill out into the peritoneal cavity. You've heard me say that blood anywhere outside the blood vessel is irritating. In the peritoneal cavity, in the stomach, in the brain, it causes pain. It does so in the peritoneum too. So when this blood spills out, some women suffer occasionally what's called Mittelschmerz, which is German for middle pain. It's the middle of the cycle. They'll suddenly get pain on one side or the other, which usually goes away in a few hours, and that reflects the irritation by the spilled blood from the Graafian follicle. Now, it eventually starts to lose its size and shape and scar down into something called the corpus luteum. The corpus luteum is the yellow body. It remains after ovulation, and it's a source of estrogen, progesterone, something called relaxin and inhibin, things that relax the uterine lining. And then the white body, the corpora albicans, is what's left after the involution of the corpus luteum. Corpus luteum is what's going to nurture the hormonal levels that are needed to keep the egg, the fertilized egg, in constant contact and in constant maturation. When that doesn't happen, then this degenerates and becomes a corpus luteum. So that's what we have coming about in the maturation of a single ovum in one menstrual cycle. More to the point, we ought to look at what happens with the whole body in the menstrual cycle, and that'll give us a very nice correlation with the hormones and the rest of the body. If we take a look at the next slide, this is a picture of the correlation between ovarian function, uterine cycles, and the hypothalamus all together in one page. Now, menses comes from the word month, and this occurs about once a month, so we call this the menstrual cycle. Where do we start the menstrual cycle? Well, physiologically, we could pick any place here. Probably this would be a good spot right here where things begin, but we don't know where this is. There's really no consistent place that we can tell, especially years ago when we didn't have chemical analysis that was precise enough. So in any particular individual having a menstrual cycle, the one place that's absolutely identifiable is the first day that blood occurs coming from the vagina. And this is back here, the beginning of menstruation, which means the bleeding, the monthly bleeding. If we try to go anywhere else, we really don't know where we are. If we try to say the first day after bleeding stops, it's very common for there to be bleeding to cease, have a day that skipped, have a little more bleeding, maybe another day. It's, again, not a very precise time. We'd like to be precise about this, so we're all talking about the same thing. So we have chosen arbitrarily to look at the first day of menstruation. What happens here? The uterine lining has actually been pretty thick and built up at that point when no fertilization took place. The withdrawal of all the hormones has allowed the uterine lining to break down because the vessels contract and the blood supply is removed. Bleeding starts right there. Now, the ovarian cycle is lagging a little bit. We have those primordial follicles, the first ones we saw developing, and they are starting to get ready. They have been built up now into a primary follicle, and finally we have an egg here that's getting ready to generate for this one cycle. Up in the pituitary, we are getting hormones that come out of the posterior pituitary, which nurture the follicles. This is follicles that are made in the ovary. And we have some follicle-stimulating hormone coming down from the anterior pituitary into the circulation. We have some releasing hormones that are telling the anterior pituitary what to do, and we start getting the generation of that follicle that you saw, the secondary and the mature Graafian follicle. Meanwhile, the estrogens that are being put into the circulation from down here are helping to build what's called the proliferative phase of the endometrium. The first part of this phase, we are adding blood supply, adding nutrients, building up literal depth in tissue. It's getting thicker and thicker and what we call succulent because it is very full of fluid, blood supply, lymphatics at that point. This phase takes us, these are the days right here, we're talking about the first half of the menstrual cycle, counting from the first day of menstruation. At this, sometime after this point, we can expect the corpus, the mature Graafian follicle to rupture. We get this corpus hemorrhagicum with some bleeding in it, and the egg has been released. Now we are depending upon the corpus luteum to continue to nurture the endometrium. And the corpus luteum is going to produce progesterone and estrogen. Progesterone is the hormone we should associate with pregnancy and conception. Estrogen is in the first half of this cycle. Estrogen and progesterone occur combined in the second half to keep this endometrium going. If fertilization occurs and the fertilized ovum and sperm material finally do enter down here, this will be perpetuated for a normal pregnancy. However, this slide shows the absence of that. We have a luteal phase here where the corpus luteum is trying to nurture the endometrium. And finally, as this deteriorates into a corpus albicans, a white scarred body, it stops putting out these estrogens, and that withdrawal of estrogen starts to shrivel up the blood supply. And we get degeneration of the endometrium, which finally literally sloughs away from lack of blood supply, and part of the menstrual bleeding is blood, and part of it is cellular material and debris, which gets us back to the very thin endometrial lining, and the cycle begins again. Post-ovulatory phase lasts approximately 14 days. It's fairly consistent. We just don't know when it starts, unless the patient has pain on ovulation or unless we do some chemical measurements of the hormone levels in the blood. The birth control pills mimic a pregnancy. What they do is they combine a very small amount of estrogen with some progesterone. And they tell the body that it is still pregnant, because progesterone and estrogen stay high in the pregnant patient to nurture the uterine lining so that the baby can grow and mature in the uterus. The birth control pill is a combination that now says, I'm pregnant, don't release any more eggs, because it's this combination that stops the ovary on either side. And they do alternate sides, by the way, in most women. 1 month, one releases an egg, and the next month the other one does. And it tells the ovary to stop releasing any further eggs until we're done. That way, you don't have something called superfecundation. Some animals can do this. They can have a baby working in the uterus and growing, and then they can get a second one that starts, so they can have one baby several weeks after another. This doesn't work in the human. It usually leads to spontaneous abortion. And this physiology keeps it from happening. So that's the physiology of the normal menstrual cycle when we don't have fertilization. Let's look at the physiology of fertilization. If we look at this slide, we have the time course of conception. Basically, here's the ovum being released into the fimbriated end, and fertilization usually occurs sometime in the first 24 hours after the little ova is ejected into this. So it's important that intercourse occur very shortly before or just after ovulation. We don't have a big window there. The reason is the sperm cannot live for more than a few days. So they need to get through the uterus, up into this tube, and get fertilized just either side of ejaculation. Well, I can't, not either side of ejaculation, but either side of this small window in which the ovum is moving down the tube. Finally, divisions start occurring here. You have first cleavage completed, and so that we have a two-celled conceptum here, then 4 cells and so on. And by the time we get down to the 4th day, we have something called the morula, which has hundreds of cells at this point. Then something called a blastocyst, which is a sphere of cells with a hollow center, occurring sometime around after the 5th day. And then toward the end of the 1st week, the blastocyst will implant into the side of the uterus. If the uterine wall is not perfectly developed to accept it, then a spontaneous abortion will occur, and this will present itself as a normal menstrual cycle. The patient may never know that they were pregnant. They'll start bleeding a week or so after they've ovulated, and they'll think they just had an early period. That's called a missed abortion. Now, when we move on to what's happening in the implanted ball of cells, we get something that looks like this. The hormones now are rising at a very steep rate, and we have something called prostaglandins in the semen that can stimulate uterine contraction and get this ball right to where it wants to be. And we have the cells here. This is the uterine cavity side, and then we have the lining of the uterus, and these are both replicating at a very fast rate. We have now the ball shown here with its hollow single layer of cells on the outside, and then an inner cell mass here that is beginning to differentiate. And finally, at about 7 days after fertilization, we're definitely getting 2 layers of cells here. And notice what's happening to the endometrium. We're starting to get cells here that are differentiating as well. We're bringing a huge blood supply to this area, and we have what is a benign tumor, the implanted blastocyst, eating its way into the wall. This is the only invasion of one tissue into another that occurs in benign, quote, disease. It's a benign process, but it mimics the invasion of a cancer. There's something called capacitation, in which a group of enzymes secreted by all the sperm, as you remember, have gotten in and weakened the wall of the ovary. That's what's allowed them to get in. And then there's an enormous number of changes mediated by a lot of different enzymes and hormones that nurture everything that's going on in both the mother's side and on the child's side, at this point, just a blastocyst. The implantation continues until you have several membranes here, and we have a huge, huge circulatory system that's parallel. And it's like many of our other circulatory systems, there should not be the mixing of the mother and the baby's blood at this point. The placenta, which develops on the maternal side here, which is going to be the future placenta, and the umbilical cord that links the baby are going to run their cells past each other, very close, again, 1 capillary apart. So the mother will exchange all her gases into the baby's blood, take out the baby's carbon dioxide, give the baby oxygen. The baby's heart and lungs, the heart will be pumping, but the lungs will not be functioning. We're going to bypass the baby's lungs because there's no air in it. The blood is not yet mixing, and we don't want it to mix because there may be blood type differences from the mother to the baby because of the father's contribution that might be incompatible. We get sugar exchange, we get the exchange of nutrients and the exchange of wastes. That all goes across the two membranes, but not red cells and not the antibodies of the blood system. The mother can give the baby antibodies. The mother can give the baby antibodies in milk too. But this blood system is not going to mix because it may be incompatible. Toward the very end of pregnancy, the uterus starts undergoing a few contractions. The placenta starts to age, and few of these blood cells and blood vessels can break down, and there can be a little mixing. And that's why when we get blood type incompatibility, we can get some of the mother's blood into the baby's system, breaking down some of the baby's blood cells, which are seen as foreign blood cells in the system that's now leaking. And that's when we get into the very late problems of neonatal jaundice, which can occur from usually the Rh incompatibility in blood. Those don't occur usually till very late, and by then the baby can be delivered. And we will talk more about delivery and some of the problems of the genetic side in our next lecture. I'd like to go on now and talk a little bit about another reproductive organ called the breast. Before the days of formulas and some of the artificial things that we can produce to feed babies, the breast was certainly a vital organ for the baby. If there was no breast milk available, all babies died. There was no other way to feed the baby. It didn't have to be the baby's own mother. It could be someone else, but the baby needed to get milk from the breast, or it could not get the nutrients or the antibodies necessary for survival. So it's an organ of reproduction. The breasts are called the mammary glands, and they are actually, as I think I mentioned before, modified sweat glands. They are apocrine glands capable of making milk and also releasing some of their structure into the duct system, so they lose a little bit of their cellular material as well, and that defines an apocrine gland. The sweat gland is another one of those. Those are the two apocrine glands that we see most often. The basic structure, as you'll see here, is called the lobule. These are the lobules of the breast. They're in clusters. There tend to be about anywhere from 12 to 20 of these groups, and these are the functional part of this structure that makes up and secretes in the non-pregnant patient just a clear fluid, and in the pregnant patient eventually milk. The ducts of these lobules are lined with an epithelium. As you can see here, they join like the branches of a bunch of grapes, and they each lead into a solitary duct which is hollow, lined with a single layer of epithelium, and they meet and drain into contiguous ducts which become bigger as they approach the nipple. There's a small swelling at the end called the sinus, which holds a little more fluid. And finally, they empty into about anywhere from 6 to 8 openings in the nipple itself. Now, the nipple is surrounded by something called the areola, a pigmented area that contains smooth muscle. And there's smooth muscle throughout the duct to help eject milk and to help the lobules get their milk down the duct. The breast is on the anterior outer surface of the chest wall. There's ribs and muscle between the breast and the chest, and a membrane here that separates it. There are also ligaments in the breast that help support the breast. And the breast is primarily divided into either breast tissue, as shown here, or fat separated by the ligaments. And with aging, the proportion of breast tissue to fat changes. This is significant, for example, in a mammogram, an X-ray. Fat allows the X-rays through. The breast tissue doesn't allow it very well. And so what happens is mammograms are far easier to interpret in an older patient because it's mostly fat and tumors show up has more dense material, whereas in the younger patient, you have a lot of dense breast tissue. Tumor can be hidden more easily in that breast. The male breast is very similar, but the male doesn't have any lobules because the male has no need to secrete milk. Evolution gave the male, a long time ago, both aspects of breast tissue, but evolutionarily we've lost this over the thousands of years, and men are left with just ducts and very little breast tissue of any other kind. So this means that men can get breast cancer, the same way women can get breast cancer, but women get both lobular and ductal cancers, cells arising in one of those two components, and men can only get ductal cancer. And interestingly, it presents the same way, it has the same treatment in a man as a woman, and often the same prognosis. It's not that different a disease. However, because of hormone considerations, there's usually one male breast cancer for about every 100 female breast cancers, and I'll talk about that a little bit later on. So the breast has a physiology that is entirely devoted to the production of milk and the milk letdown, which is called lactation. It's under the control of oxytocin from the posterior pituitary. Remember, we talked about that when we talked about the pituitary. Oxytocin also controls uterine contraction. That's the Pitocin during induced labor. And there are other chemicals and enzymes as well as hormones that are involved in the process. There's something called prolactin. Estrogen and progesterone are all involved with milk production. Now, when a patient delivers, that patient needs to make a decision in this modern day as to whether she's going to breastfeed or not. Because if she doesn't breastfeed, short of pumping milk from the breast manually, that breast is going to fill up, become engorged with milk. It will stretch the tissues, make it painful, and because of the stagnation could lead to inflammation and infection. So what you don't want to do is have a patient start breastfeeding and then quickly stop. What we do is we give patients certain drugs which antagonize the milk letdown at the time of delivery so that the patient will never start making milk at all. It's harder to stop once the milk production starts. And with continued breastfeeding or pumping, that stimulates the whole cycle of progesterone, prolactin, and estrogen to keep the milk being produced. The more you breastfeed, the more milk is produced in the system. So once you start this, you really want to keep it up or shut it down completely. Let's talk a little bit about breast cancer since we brought the subject up. It is the #1 cancer in women, but it is not the #1 killer of women. Breast cancer occurs in women more than, for example, lung cancer, but it is a highly curable cancer in many cases. But since women started smoking, they've actually caught up with men in the incidence of lung cancer. And since lung cancer is almost incurable, more women will die of that proportionally than they will of breast cancer. There are risk factors in women which include, #1, cancer in the opposite breast. Since your closest genetic relative is you, then the same factors which cause breast cancer in one breast would be at work in the other breast. So a prehistory of breast cancer in one breast raises your risk in the other. Nulliparity, meaning no childbirth. All the risk factors I'm going to tell you have to do with prolonged exposure to estrogen. And when we get to the last lecture, I'll show you how estrogen works. But basically, estrogen is the culprit here. Prolonged exposure to estrogen is what promotes the breast cancers. So a woman who starts early onset of her periods, menarche, and or has late menopause is going to have many more years of estrogen exposure. Non-pregnant, so it's not opposed by progesterone. Progesterone opposes the actions of estrogen. Family history, first-degree relative increases risk. Breastfeeding used to be thought to decrease risk. It probably doesn't. Anything that prolongs your estrogen, however, having had no children, increases the amount of estrogen you've been exposed to, whereas if you've had lots of children, you have that period during pregnancy and during breastfeeding when you have progesterone in the system. So that decreases the numbers of months that you've been exposed to estrogen. Therefore, patients with no children have a higher incidence than patients who have had children. And there are gradations. Having relatives with first-degree relatives, mother, sister, maybe grandmother on the maternal side, increases your risk. If those patients have had bilateral breast cancer, that increases the risk as well. So we put these all together. The problem with this is most patients with a family history have had, do not develop breast cancer. Most patients who develop breast cancer have no family history anyway. So these details give us information that we really can't translate to use in any individual patient. They're interesting, but they don't help us treat the patient. That's the end of our look at the female reproductive system. And next time, we'll move on to some more of the physiology of reproduction.